problem solvers, to the Friday edition of RLR Virtual Morning Report. We hope that wherever you are in the world, that you're doing well, that your family is doing well, and your loved ones are doing well. Robbie will be joining us shortly, but in the meantime, I want to request a case from an audience member, preferably someone who hasn't presented yet. That would be awesome to have you present. We are very friendly. We're not mean. You'll have a good time. With that being said, I'm going to pass the mic to Andrea just to let us know how she's doing, what her plans are, over the next couple of months, because Andrea will be doing the teaching points, and then to pass the mic to Rafa to also tell us what he's up to and what his plans are over the next couple of months.
Hi, I am Andrea. I am a medical student in Peru. I'm a research assistant at Buffalo, New York, and I applying this year to internal medicine residency.
Hi, everyone. My name is Rafael. I just graduated from medical school here in Brazil. I'm also applying this match. Actually, just received my step 2 result. Thank God. It was accordingly to what I expected. And also next week, I have my OET exam. So please send good vibrations. Pass the mic over to Reza.
Congratulations, Rafa and Andrea. So we haven't had a volunteer yet, but the CP Solvers always has a backup plan, because you got to be prepared so you don't have to get prepared. I'll wait one more minute till 9:05. If no one volunteers, we will proceed to our backup plan.
Reza, tell us about your future plans.
Oh, sure. Actually, so I was supposed to fly to San Francisco at 10 today. I'm going to be staying with Robbie and Nar because Uncle Bob is actually traveling to San Francisco, or he may already be in San Francisco, because he has a new grandson. For those that don't know Uncle Bob, that's Bob Centaur, one of our advisors and mentors. But I just learned that my flight got canceled. Not just last night, they told me it got canceled. So now I'm flying out at 4 p.m. So my immediate future plans, Rafa, the acute plans, is going to be hanging out with Robbie. Long-term plans is I just am making a bunch of teaching videos. I just read about methemoglobinemia for like 10 hours over the past couple of days, and I finally understand it. So hopefully today's case is methemoglobinemia, because I will succeed. All right, Kiara, take the mic over. No one has volunteered. Tell us a little bit about your future plans, and then you can start presenting whenever you're ready.
Yeah, so I am Kiara. I have a case. My future plans. I will try to apply this year. I'm studying for the CK exam, and maybe if I cannot apply this year, I apply next year. So yeah, that's the plan. Okay, so I can start this case with just the chief complaint with rash.
Wonderful. And we'll stop there for a number of reasons. How many of you are nervous when the chief concern is rash? Put your arms up, your virtual arms up in the air, or your physical arms up. I'm going to put 2 arms up. Why? Because if you think about it, how do you get great at solving or reasoning through various cases of rash? It's by seeing thousands of rash, but none of us will see. I just see Robbie join us in the audience with his, hey Robbie, how are you?
Remember when I joked yesterday over text about the picture with Nar on the ball and you with the whiteboard. It's like coming to reality now. Whenever I see my dog, I see his ball. Whenever I see Reza, I see that whiteboard. It's beautiful. It's just absolutely beautiful.
Well, so nice to have you, Robbie. So I'll spend a couple minutes here and then we'll get more data from Chiara. But the point I was making before I was rudely interrupted by Robbie was that the dermatologists, they develop pattern recognition. So for them, when they see a rash, it's like seeing a face. Like, oh, that's Robbie, that's Chiara, because you see the face so frequently. But if you're in internal medicine, you're dealing with so many different problems that rash is just one of many. So we have to be much more analytical. And for me, in dealing with rash, I'll teach you a few main points that allow me to make more progress. One, looking at the rash. Looking at the rash. This is like one of those scenarios where you look at the rash and you let that guide your history. Two, whether there is inflammation or not. This is a major branch point because if you have inflammation and you have rash, then you're activating your fever and rash schema, which includes life-threatening etiologies like Rocky Mountain spotted fever or toxic shock syndrome. So number one, look at the rash, let that guide your history taking. Number two, determine if there's inflammation. And then the general framework is the following. Are we dealing with an internal process that's showing itself on the surface, meaning that internal process is creating this sort of milieu that then leaves a signature on the skin? Or are we dealing with an isolated cutaneous process, meaning an external process? How can you make that distinction? Well, let me ask you, if I told you the rash was diffuse, would you think it's an internal job or an external job? Put it in the chat. If I told you that the rash was focal or in one location of the body, external job, like a contact dermatitis, or internal job, like a malignancy. I will pause there because we're going to need much more data. And the last thing I'll say just about rash is the fourth pillar of approach to rash is review the meds very carefully. Review the meds very carefully because they end up being a culprit in far too many cases, almost like a patient with really high AST and ALT. Always review the meds, apply the same filter to the rash. So with that being said, Chiara, mic to you. Oh, it seems like we have a question. Raisa, do we have a question or is that a clap? Oh.
It was just a clap.
Oh my gosh, keep them coming. All right, mic to you, Chiara. Oh, Chiara must be frozen. While we're waiting for Chiara to come back, Robbie, I really loved your, because you have you augment the approach. Can you share what is your approach? Like what other principles you take into consideration? There's something you say that's really cool.
Can I tell you something? This is a little bit of a secret. Is whenever somebody compliments you like that, it's always a pleasure. But if you know that what you have to offer is nothing really, just add some fancy smancy words and it'll sound different, but it's really just going to be repetitive. So yes, I'm happy to add whatever, but really I'm just going to be repeating it. And for me, when I see the words rash, I immediately go into clarification mode rather than solving mode. And what I immediately want to know is the width of the rash. Where does it extend? And I want to know the depth of the rash. So it's width and depth. And then I'm listening for alarm symptoms. And the alarm symptoms are pain and any systemic features. And only then do I begin to solve the problem. So width, depth, and the third dimension is any alarm features. It's no different, I think, than you trying to solve the problem when the patient has only said the following: Ra, without the sh. It's equally unproductive to try to finish the patient's sentence than to try to solve the problem when the patient has finished the word rash. It's not yet a clarified problem. So just like Prof. Rez, I'm in much more data gathering mode, and how you choose to like put the labels associated with them are different words we use, but we're both saying the same thing. How bad is it? Where is it? Before you don't try to come up with an answer, try to come up with a better characterization of the problem.
And Robbie, just to, I guess, go back and forth a little bit. We had a question in the chat with how do you determine the depth? And then talking of alarm features, I mentioned one of them being inflammation. Another one would be pain. Another one would be mucosal involvement. Anything else that you add to those?
No, I mean, in fact, since we have time, I don't see Kiara yet, but I might be missing it. I'll just show up a visual so that
I'm here.
you're here.
I'm
Hello.
back.
Okay, let me just show this picture real quick and then we'll get more data from you. So
Yes, of course.
this is where we're at. So I'll show you, maybe I'll try to put it up later. I actually have the alarm symptoms in a separate schema. But this is the kind of lay of the land that we're trying to get. Sorry, I actually pulled up the wrong schema. Here it is. So you want to get the width. How horizontal is it? What's the body surface area that involves a rash? Is there mucosal involvement? You want to get the depth. And here are the things for depth. The more painful it is, the deeper it is. If there's blistering involved, so you see blisters, that's deep. There's necrosis, like black or purple. There's nodules. That's pretty deep. And then I think another big thing is evolution. So what happens over time? This isn't comprehensive, as you can tell, and I agree. Inflammation and things of that nature can definitely make you worried as well. But this is the kind of like immediately, how wide is it, how deep is it, and how quickly has it progressed is very helpful. All right, Kiara, mic to you.
Okay. I'm sorry, my internet connection was very bad. Okay, so a little more of the HPI. This disease start 15 days before his emergency admission. He started with respiratory symptoms and fever 15 days before. Then 10 days before, he started with erythema. It was painful and pruriginous in the right hemithorax. Then 7 days before admission, this rash in the right hemithorax self-resolved, and then 7 days before admission, there was the same characteristic rash in the elbow, associated again with fever. This again self-resolved, and 5 days before admission, this was in the forearm. This rash with the same characteristics was in the forearm. And after that, self-resolved, and 3 days before admission, this rash was in the wrist. This is why he went into dermatology and rheumatology consults, and they look at this rash and they said him to come to the emergency department so he can be hospitalized. So he came to me at 3 a.m. in the morning, and I did his admission, and I found this characteristic rash, which was painful, pruriginous. At this time, it was in the wrist. It was tender in the flexors of the forearms, and yeah, that's what I saw in his arm. Then a little more of the HPI. He is a 27-year-old male. He is a bachelor in engineer. He lives with her 15 days. He lives with her girlfriend, and he does regular exercises. He haven't got COVID recently, he had a recent travel to the north coast of Peru, which is Máncora, and that's all we had.
All right, this is such a rich history, and I'll just share some reflex thoughts and pass the mic to Prof. Rez for zooming in on whatever he glances. I think that the only progress you can make with this is to be alarmed by the sheer number of words you're hearing. When most patients describe the rash that they have, the spotlight is focused on the rash. It often is mild in severity, and at most it's intensely pruritic. And here there's so much color and decoration to this presentation. And so I think that it certainly augments the process that we're dealing with a systemic disease with cutaneous manifestations. And the evidence for that, just to list it, is the progressive, relapsing and remitting nature, along with the visceral symptoms of shortness of breath. So I can't make any specific progress beyond saying, I need to study the two clues of this case, the rash in more clarity, and the physical exam findings of the rash. And I also need to study what the thoracic dimensions of it are. And if we call this a parenchymal pulmonary disease process with migratory targetoid rash, is very different than saying it is a cardiac disease with a desquamative rash. And I'm just using those buzzwords to say this could be mycoplasma with erythema multiforme, or in the opposite corner of the diagnostic world could be a young person with Kawasaki's disease and have cardiac involvement and have cutaneous involvement. Both of those are incredibly rare diagnoses, but they illustrate the spectrum of possibility here. So you really, really have to try to pin down, I think, what the thorax manifestations are, what the cutaneous manifestations are. That's where I'm at. Prof. Rez, where's your mind going?
You know, I think something that's so peculiar about this, if I am understanding it correctly, is this waxing and waning nature of the rash. I think that's such a unique characteristic that although I don't have a thorough differential diagnosis for it, I don't want to shy away from that finding. And I actually want to lean into it, because maybe by the end of this case, we'll view that specific finding as a clue to the final diagnosis, but I'll share my general thoughts regarding it, the waxing and waning nature. If basically you're asking what diseases are not just monophasic, but show themselves, disappear, show themselves, disappear. To me, what it makes less likely is a typical bacterial infection, like a typical bacterial infection. Because remember, when we said fever and rash, you have to go through the life-threatening etiologies, such as meningococcemia, necrotizing fasciitis, Rocky Mountain spotted fever, and toxic shock syndrome. Usually those causes, they don't have this waxing and waning phenotype. So now when you're thinking of infection, when you're thinking of rash and fever, you're like, is there an infection, a cancer, an autoimmune, or some kind of drug exposure? But even in the infection category, like think about it. We often think of fever and rash in a young individual. What should that make you think of? Infectious mononucleosis. Like, let's play base rate of disease here from HIV, EBV, CMV, but that wouldn't have this waxing and waning phenotype to it. We think of syphilis, but again, syphilis to come and to go, I don't like it. I really don't. And typical bacteria shouldn't do this either. Neither should other viruses like parvovirus and stuff like that. So if it is infectious, it has to be an atypical infection, not even fungal, because of the fungi, cocci can cause a rash. And we do have this pulmonary signal, potentially pulmonary signal, but it shouldn't cause a rash like this. So I like what's being said in the chat of potentially something like parasitic that's like showing up on the surface, going away, but I don't have a great illness script. As far as like endocarditis, yeah, you can get rash in multiple locations, but I don't see it resolving in a couple of days. That would be odd as part of that phenotype. So I think we need much more data. But right now, if it's infection, it's an unusual infection. If it's malignancy, you could imagine potentially having flares and remission. If it's autoimmune, that's another process. But boy, it's very hard for me to think of it unless like you had like a neutrophilic dermatosis, but that shouldn't come and go like this. Anyways, all that to say is I'm thinking out loud. This waxing and waning nature is very, very unique. And maybe a clue to the final diagnosis. And Kiara, if you can just let us know, you're telling us it comes and it goes, or is it comes, it stays, and then it goes to another location?
Yeah, actually, it self-resolved when first appeared in the right hemithorax. It self-resolved and then appeared in the elbow, self-resolved, and then in the forearm, and then in the wrist.
I am so excited to see what the final diagnosis is. That's so unique. All right, Mike, to you, Kiara.
Yes, it was a very interesting case. So vitals were okay. He had a mildly fever at 38 Celsius. Otherwise, he was okay. He also had a slightly abdominal pain on palpation in the upper quadrant. So after that, everything else was fine. And now the description of the rash, which by that time I saw him, was only on the wrist. So it was an erythema in the forearm, but mostly in the wrist. It was painful in all the trajectory of the extensors, and there was a passive limitation in the wrist. It was limitation on passive movements. So it was cataloged at first as a Tenocytovitis, and I have a picture. It's not very well cleared. I have the permission to show that picture, don't worry, but there's no face or something. So, yeah, so this is the wrist. I don't know if you can see it very well, but it is here. It was erythematous, and it was like mildly edema in both sides of the wrist, and it was painful in all the extensors. So this is all for the vitals and physical examination, and I can stop here.
Great. I'll leave the picture of the rash for Robbie, and I'll tackle all the other dimensions of the case. As far as the other dimensions of this case, really, this is a tough case. Let's just be honest. So Robbie and I were going to do our best to make progress with the image. But I think right here, we verify that the patient's inflamed and is meeting many of the alarm features that was on Robbie's schema, from the painfulness, the tenderness. And what my mind is doing now, it's adding additional organs or organ systems that are involved by this systemic process. So we haven't yet excluded a pulmonary or cardiac manifestation. We're seeing cutaneous, that's waxing and waning and migratory. We're now getting signal to arthritis. So far, a single joint, not multiple joints, but whatever this disease process is, seems to be involving the joint as well. And then we learn about this abdominal exam. And you wonder, what is causing the tenderness? Meaning, could it be something that's also involving the vessels of the abdomen, for example, or just deeper within the subcutaneous tissue that's leading to pain, meaning whatever process is causing this disease? The challenge here is knowing what's bystander, meaning not truly that helpful to the final diagnosis, versus what is like clue of where the pathology exists. I think we can all agree that the skin is prioritized. The joint, boy, it's if there is arthritis, you just wonder if you can safely perform an arthrocentesis to get more data. With the abdomen, I would have a very low threshold actually in this patient who's young and has these subacute symptoms to get imaging to better understand the lay of the land in a CT with contrast. But yeah, it's really hard for me to make progress besides saying I'm worried. And I don't know how many different organ systems are being affected by this process, but I'm worried about the lung, the skin, the joint, and abdomen NOS. Mike, to you, Robbie, I'm quite perplexed.
Well, Professor, I'm so excited to talk about this part because I think these are the kind of things that happen in urgent care that we don't talk about on VMR. So thank you for passing on the rash. I think that if I saw this in real life, which actually happens very often, just yesterday we had a patient with a knee arthritis and that we had to tap that you'll hear about on RLR. Anyway, that decision to tap that knee was very easy because there was no overlying erythema, that ankle, excuse me, was no overlying erythema. Here you have a wrist that's swollen, but that it's red over it. So let me just explain why people would be concerned about solving this problem. Is okay, the most morbid diagnosis to entertain when the wrist is swollen and there's overlying erythema is septic arthritis of the wrist, right? But what if there is no septic arthritis and you accidentally poke cellulitis and bring it into the wrist? So this exam, knowing how to actually distinguish a wrist process from intra-articular or peri-articular is key. So I'm going to pretend like my wrist here. I'm going to try to figure out how to hold it. So you realize this is super important. So the wrist was swollen and inflamed right over here, right? And so in order for you to figure out if it's a wrist problem, you might be tempted to ask the patient to do this and see, hey, does this hurt you? And that is not going to be helpful. And let me explain why. When somebody's skin is inflamed and irritated, you're moving the skin too. Look how much the skin is moving. That hurts a lot if you have cellulitis. So what you have to do is you have to isolate the wrist joint by squeezing like this on the wrist without moving the skin. So you put your hand here, and squeeze. That allows you to determine, it's called axial loading, if the problem is in the wrist itself. Now here, by the pattern that Chiara presented, with it being a more extensor tendon predominant, I'm a little worried that it actually represents Tinocenovitis or tendon, inflammation of the tendons in the wrist, not the joint. And how you would determine that is by asking the patient just to flex their fingers and to see if that moving of the tendons, don't move the wrist, just move the fingers like this, if that brings out the pain. So now you can make a lot more progress by calling this problem a febrile thoracic abdominal skin problem, or a febrile thoracic abdominal tendon problem, or a febrile thoracic abdominal intra-articular problem. Very different diagnoses with very, very simple and actually pretty reliable physical exam findings. So Chiara, did you have a sense of that impression, if this is a problem in the wrist joint or the tendon or the skin, or was it hard to figure that out?
Yes, it was mainly tendons, so this is why it was considered like a tenosynovitis.
Yeah.
Yes.
Yeah, I think, we can share a differential diagnosis of tenosynovitis, but I think you probably wouldn't do that right now. You'd probably be like, let's get that data. Let's see what the abdomen does. Let's see what the thoracic evaluation shows. But it's tremendous progress to look at that wrist and say, not the skin, not the joint, but actually the tendons. That is no different than abdominal pain, liver, dyspnea, lung. That progress is very, very powerful. So kudos to you for leaping to it. Okay, I'll pass the mic to you to tell us some more.
Okay, great discussion. And okay, I don't have the complete labs. I don't know why, I'm sorry, but I can tell you what I remembered. So he had normal, I have it here. Hemoglobin was in 14.7, leukocytes 7,200, platelets 200,000. ESR was normal. Yeah, there was differential was predominance of eosinophils in 25%, and electrolytes were normal. C-reactive protein was slightly elevated in well, not slightly, it was 2.2. Then some further labs were taken. Proteins were okay in 7. Albumin was okay in 4.5. Alphos was okay in 66. Transaminases were okay. Creatinine was okay too. Some rheumatologic labs were taken, and rheumatoid factor was 8.3, which was okay. Then SSV, anti-SSA and SSV were okay. Anti-ribonucleoprotein was okay. Anti-Smith, ANA, ANCA were okay. Epstein-Barr virus IgM, the VCA antigen, was okay. Etna was okay too. Then HIV, HTLV were no reactive. And this is I have one more aliquot before the final diagnosis.
Oh, this is so intriguing, Kiara. Maybe I can just reflect on the pertinent negatives here and pass the mic for one of my favorite things that Prof. Rez discusses, which is eosinophilia. And I think that what I'm struck by, Kiara, honestly, is that the labs for the abdominal dimension didn't reveal anything. So when you're thinking about it, like what causes laboratory negative kind of subtle abdominal pain? And I think that, the honest answer is many things. It could be cholecystitis, it could be gastritis and enterocolitis. But there was no definitive right upper quadrant pain to suggest that hypothesis. And there was no diarrhea to suggest the latter. And so you're wondering like, hey, this person having kind of weird abdominal pain. And I haven't found, I found a specific answer. And, when you immediately layer that on with the eosinophilia, it's not hard not to worry about there's some sort of luminal disease process that's causing migratory parasitosis. But I think pay attention to the pertinent negatives here. I think when somebody's abdominal pain doesn't show up on the labs, where could it be? And it's probably lumen as a notorious cause of lab negative abdominal pain, or vessel. I'm trying to think if there's any others, honestly, but those would be my priorities. Is like, hey, I'm worried about this person's abdominal pain. The labs haven't given me any guidance whatsoever. The most common cause in real life is probably like peptic ulcer disease. The most scary would be some sort of mesenteric ischemia. But that certainly is a very helpful pertinent negative. All right, Prof. Rez, mic to you.
Finally, something that I can discuss. The truth is, when you are problem solving, if you think about it, it's very difficult to prioritize a specific diagnosis in the first couple of aliquots. As the information is coming to us, we can start becoming more and more focused. Like fever and rash, very broad differential diagnosis. Fever, rash, and Tinocenovitis, much narrower differential diagnosis, being the Tinocenovitis. Now you have fever, rash, Tinocenovitis, and eosinophilia. And so as a problem solver, you have to select one anchor point. You can't be thinking about each of these simultaneously. You select one as the anchor point. Then when you're going through that differential diagnosis for your anchor point, you ask the question, can it explain the other pertinent findings? This is very important when it comes to solving a difficult case. So like my anchor point wouldn't be fever here. It wouldn't be rash. It might be this migratory phenomenon, but your anchor point in this case, what would it be for you? Maybe for different people, it's something different. Maybe for Robbie, it's Tinocenovitis. And actually, Robbie, since we have time, I think a fun exercise would be to use Tinocenovitis as an anchor point and then see if it does the EOs, if it does this and that. And then I'll use the EOs as the anchor point because it's like two different frames, but you need an anchor point. So the easiest anchor point is eosinophilia, and that's probably the one that most would select in this case. And with eosinophilia, you want to look at the absolute number, but you have to be cautious here because the absolute number doesn't necessarily reflect the degree of eosinophilia. You may be like, what? That doesn't make sense. What do you mean? What I mean is that eosinophils can be in tissues without being measured in blood when you do the CBC with differential. So the absolute gives us a clue, a pretty good clue, but not a perfect clue to the magnitude of eosinophilia. Doing this math, you're looking between like 1,500 to 1,700 eosinophils, and you can rank it as mild, moderate, or severe. I would say that's like moderate eosinophilia. I believe severe, you start getting north of 2,000. These are just, in my mind right now, arbitrary. I'm not looking at any references, but we're dealing with significant eosinophilia. Right off the bat, you can exclude two processes, bacteria, most bacteria and viruses in the infection bucket, because these lead to endogenous steroids, which causes eosinophilic apoptosis. Then the question becomes, where does eosinophils cause damage? This is where you have to think about the organs exposed to the environment, being the lungs, the GI tract, the skin, this patient has skin involvement, and the heart. Could that be a part of the, pulmonary, signature of this underlying disease? So these are the most common: lungs, skin, GI, heart. Now you're finally ready to go through the differential diagnosis for eosinophilia. This is our anchor point. Then we're going to say, can it explain the other findings? I'm not going to comment on the Tinocenovitis because I really want to hear Robbie's approach to that and as the anchor point. The eosinophilia, the first question is, could it be primary? And what do we mean by primary when we say that in medicine? Basically, eosinophilia without a secondary cause. So how can you determine it? Well, you got to rule out the secondary causes, or you have a primary eosinophilic leukemia. The way you diagnose the latter is you do a bone marrow biopsy and you can do studies. You can put hypereosinophilic syndrome under that bucket as well. So you have sort of idiopathic eosinophilia, leukemia, hypereosinophilic syndrome. Could all this be one of those? Of course it can, because eosinophils involve the skin, they involve the lung, and it can be inflammatory. But let's go to the secondary causes, because that's really where we want to anchor ourselves. Can this be adrenal insufficiency? No, it can't be. The eosinophils are too high, and it wouldn't explain the other elements, the rash, the fever. Could this be an allergic reaction like atopy, reaction to a medication? Remember, drug-induced hypersensitivity syndrome. Well, you look at the list there and there's no meds. And furthermore, that often, drug-induced hypersensitivity syndrome often leaves a signature in the liver, and it causes a leukocytosis, but this is just not consistent with sort of drug exposure. So now we get into the interesting stuff: cancers, infections, and autoimmune processes. With regard to cancers, it's not just any cancers, it's lymphoma primarily, and then solid cancers of the GI tract, the lung, can lead to eosinophilia. Could this be, can lymphoma explain the rash and the fever? It can. Could this, if this ends up being lymphoma, would that be absolutely shocking? No, it wouldn't. Lymphoma could do this. You might say, well, look at the platelet count. I'm looking at the platelet count. It could be normal in lymphoma. But again, like for lymphoma to primarily come with this degree of eosinophilia, unlikely. I don't like cancer. Autoimmune causes is really EGPA, eosinophilic granulomatosis with polyangiitis. That I don't like because we don't have X-ray findings yet, but if Chiara shows us X-ray findings with opacifications, then it'll grab my attention more, but it could cause the other pertinent findings being fever, pulmonary. Then you're left with infections. And I think this is the most interesting bucket. And here you should prioritize fungal infection, parasitic infection and atypical bacteria. Mycobacteria can cause eosinophilia, but not to this extent typically. So you're left with fungus and parasites. Fungus, so you look at the other elements, the rash, that's not common for fungus. It just isn't. Cocci can cause a rash, but for it to be this sort of migratory waxing, unlikely. So then if it's infection, which is would best explain every other element, Tinocenovitis for Robbie, it would be something that's parasitic. Which parasitic infection? Go on UpToDate and look at the list, whichever one causes these complex of symptoms. So with that being said, I would love to pass it to Robbie just to educate us on Tinocenovitis and how we can maybe link it to the eosinophilia.
Prof. Rez, what a beautiful overview of eosinophilia every single time. Every single time. It's like me with rhombocytosis, I think. You're just like, these are like pins forever. Tinocenovitis is a really important thing to upload in your mind because it is a medical emergency, because the tendons are a highway for infections to go from here all the way down the tendon sheath. So it's a highway for rapid spread. So when you hear the words Tinocenovitis, I need you to develop a reflex forever and ever, not even to think. Staph, strep, gonorrhea, every single time. So when somebody comes in with Tinocenovitis, vancomycin, ceftriaxone right away. Now, you can talk yourself out of it by saying, oh, this person has had Tinocenovitis for 3 weeks. Okay, maybe not right away. Maybe think about it. But that should be your reflex, staph, strep, gonorrhea. Okay, now if you want to understand Tinocenovitis, we have to go into a different room, because understanding is very different than reflexes. Understanding Tinocenovitis is emphasizing the itis, is there's an inflammatory disease process, and we go back to Prof. Rez with the trusted mnemonic of IMAID. And the good news is that Tinocenovitis, there's only really 2 disease categories that cause tendon inflammation. Endocrine diseases don't do it, drugs don't do it, cancers don't really do it. It really is infection and autoimmunity. And so infection, staph, strep, gonorrhea, staph, strep, gonorrhea, staph, strep, gonorrhea, say it over and over and over again. But non-staph strep gonorrhea, it actually gets interesting. So syphilis is notorious for doing it, as is a spirochete that is present in many parts of Peru called yaws. It is very similar to Treponema pallidum. It's very, very common, but actually doesn't cause a systemic syndrome. So you can learn about yaws as the non-syphilitic spirochete. And then the other atypical organisms are some granulomatous diseases with mycobacteria, Brucella, and Coxiella. So again, what's the infection lay of the land? Staph, strep, gonorrhea. Think about other sexually transmitted infections, syphilis and yaws, and then the granulomatous diseases, with mycobacteria being the most common. The most common mycobacteria is actually Mycobacterium marinum. So when people put their hand in fish tanks, they can get a Tinocenovitis from Mycobacterium marinum. There are some fungal organisms that can do it, but honestly, I'm sure they exist, but I don't know of any parasitic organisms outside. In this case, might prompt me to do that. So I'm trying to learn as much as I can from each case. So I didn't do any Googling or research now, but I would not be surprised if there are parasitic causes of Tinocenovitis. I just don't know them, which is Prof. Rez is sweating bullets here.
Well, Robbie, this is so cool. So it seems that if the Tinocenovitis is the anchor point, and that's the finding, it must be explained, we would prioritize Mycobacterium, specifically Mycobacterium marinum.
100%.
But,
go ahead.
Oh, no, go ahead.
No, keep going, finish your thought.
No, say it.
I was just going to say, like, you might start to enter the autoimmune category, right? Like the other arm, which is to say it's been 15 days, rheumatology has been consulted. Is this an autoimmune cause of Tinocenovitis? And I'll just share with you a short list. The most common autoimmune cause of Tinocenovitis is going to surprise you. The textbook will tell you that it's the spondyloarthropathies, reactive arthritis, ankylosing spondylitis, IBD related. And IBD related can cause IBD can cause eosinophilia, though not to this degree. But the most common cause is actually gout. Gout.
I want to go on record to say this is not gout.
Yes, I completely agree. You want to know what I want to go on record on? I want to go on record in telling you this is the one time I will probably ever get to say the following word on VMR without meaning you, all of you listening to this. This case is not going to be this answer, but you should always think about this syndrome whenever you have eosinophilia and rheumatological conditions, and it's called NERDS syndrome. For all to remind you of all you bunch of nerds. N stands for nodules, which are in a tendon distribution. So N is nodules, E is eosinophilia, R is rheumatism, D is dermatomyositis, and S is angioedema or swelling. So for the sake of entertaining you, this case could be total nerds, but it's probably not. I'm having a hard time having an overlap of prof res. And if I were to stretch myself, Mycobacterium is probably at the top of the list, honestly. And I would be curious what exposures he had in his trip. I think a stretch would be IBD causing eosinophilia, like a real stretch, honestly. And the most extreme stretch would make me like have my jaw on the ground. It would be that Kiara says, oh, this is nerd syndrome. And I would probably quit medicine forever and ever and ever. It would be the peak. But now that I've nerded out, any thoughts have come to your mind or any other things you want to share before we pass the mic to Kiara?
No, I think the most important part of this exercise is just finding an anchor point and then explaining the other most pertinent data, because the Tinocenovitis narrowed the DDX, but so did the eosinophilia. So where I am right now is this Mycobacterium or is this a parasite? That's where I'm at. I just don't know enough about parasites and Tinocenovitis. If I read that there's no chance that a parasite can cause it, then Mycobacterium is prioritized. If there is a parasite that can cause it, I like the parasite based on the migratory nature of the rash and the degree of eosinophilia. That's where I'm at, and I'm happy to learn.
I love this discussion, and I cannot look at the chat because my face says a lot. So I can't keep smiling and laughing and everything. Okay, some more images. Chest radiograph, chest X-ray was fine. Abdominal X-ray was fine. Right arm X-ray, which was the one affected, showed some edema plus, some just edema and mild moderate Tenocytovitis of extensors, the first, second, third, and fourth extensors. Then, that's all for images. Then, so I'm going to reveal one extra information. The next step was checking up to date, literally. And after that, we made some further questions to the patient. So he told us that he ate sushi, which is a raw fish in Mancora a month ago in his prior trip. So that's what led us to the final test, which was a biopsy. And with that biopsy, we had the final diagnosis. I don't know if you want to guess the final diagnosis.
I see we have this actually, Amr, do you want to unmute yourself? You were the first person to list that diagnosis. And tell us why you think it is.
I have to be honest here. I cannot take the credit. I don't remember who wrote it first, but I was like, nattostomiasis was not on my mind. I knew that it had a weird mouth and that's it. Like the only thing I thought about when I heard of that is the creepy picture of the parasite. So I looked it up. I started looking up all the other ones that I wasn't very comfortable with from the chat suggestions. And this one is the one that's associated. And I was looking at their geographic distribution. This one is in southern Mexico all the way to like the northern edge of Peru. So, and western South America. So in this kind of region. So it fits with his travel history. And then I was asking about because it's a parasite you get from consuming raw fish. But it's not my idea. Someone else needs to take the credit for this.
I'll take the credit. Thank you, Amr.
Actually, it was Jasmine who told that diagnosis very early. very early. So I stopped looking at the chat because Jasmine told something like natostomiasis, and I was okay. That's all.
Can we
I
get
quit.
Yasmin to unmute herself really quickly?
Oh yeah, hi. Yeah, it was from the beginning I thought parasitic, I think, and then I remember that migratory rash and eosinophila was parasitic, and there is like trichinosis, strongyloidiasis, loasis, but loasis like for people who go to Africa, like nastostomiasis, toxopariasis, and paragonomiasis. So it was one of those.
All I heard was Eosinophils over and over again.
Yeah. All those parasites, yes.
That was incredible. Absolutely incredible. Yeah, Prof. Rash, you were saying something?
Yeah, can I just say one thing because I know we're coming short on time. I'm just going to do a quick cognitive autopsy. I just love this case so much because it forces you to anchor on a specific finding. And I think when I do my cognitive autopsy, the anchor is really this eosinophilia and this migratory relapsing remitting rash. I think that's the anchor that leads you to prioritize this specific diagnosis. And of course, the exposure history is helpful, but it's just so unique, so you don't need to know everything. It's just identifying uniqueness in problem solving will get you to the answer usually, like my chin is numb. Mike, to you, Robbie, and then, yeah.
Yeah, no, thank you, Prof. Rash. I hope Kiara isn't fooling us by pretending she agrees with Yasmin's diagnosis and tells us the biopsy shows something completely else. So I'm open to the Kiara fake out. But I think that the other dimension of the cognitive autopsy is to ask yourself, how much illness script flexibility do you have? And I promise you, when you start to read about gnathosomiasis, you'll see that the words eosinophilic paniculitis are the most common, and that eosinophilic meningitis is the most feared complication. So paniculitis, which is inflammation of the fat, is you'll see that over and over again. How often will you see eosinophilic Tinocenovitis? And while Prof. Rez was speaking, I Googled it and I can't find a single description of eosinophilic Tinocenovitis. And it goes to show you that like sometimes you can get overly attached to certain manifestations of the disease. And here now, with especially if it's biopsy proven, you may have to adjust your illness script for gnathosomiasis to say it's not just paniculitis, but it's actually just more, maybe just you should just think of it, as Yasmin said, with eosinophilia and any migratory rash. So that I think is another kind of humbling lesson. All right, Kiara, Mike, to you, my friend.
Okay. No, don't worry. Maybe you don't have to change at all your schema. I mean, all the images said that it was Tinocenovitis, but biopsy showed paniculitis, eosinophilic paniculitis, and compatible with nastostomiasis. So don't worry at all. Here's this. I don't know if you can see paniculitis, but it is in Spanish. So yeah. Yeah, so this was a final diagnosis. It was, oh, I can't see anything. Okay, so it was eosinophilic paniculitis due to nastostomiasis, which was very compatible with the history that the patient told that he consumed raw fish many times in Mancora, which is a very well-known place in Peru to go surfing and going to the sea and everything. So yeah, and yeah, it was a great case actually. Very funny.
All right, texted me yesterday and you said, oh, guess who has an incredible case? And I was like, no. And just so humbled. It's always such a treat to go through these cases. And I think my hope today is like definitive proof to the fact that like we just all learn so much. Even the person who knows the answer immediately, Yasmin, sets off a fire chain for other people to recognize the answer quickly. Unfortunately, the fire chain didn't include Reza and I, but that's okay. And I would just say, like, for those of you who listen to this eventually on YouTube, this is the reason to join in real time. It's not so that you learn from the people who are facilitating. It's that the chat is just another level of education and camaraderie and community that, yeah, it's always worth. I won't share what Robbie Takedown is happening in the chat right now. I'm too embarrassed. But thank you, Chiara. It was a delight. Thank you, Yasmin, for educating us, and Amr for taking that thought and making it and learning from it so quickly to the point where you were confident it was the answer as well, and many others did the same. And yeah, I'm excited for Andrea to take us through the journey again and emphasize the learning points.
Thank you. Yeah, we started with a rash. First, we have an approach to rash. We just look at the rash and look for patterns. If there is any inflammation, look for Rocky Mountain disease or toxic shock syndrome. Differentiate if it is isolated cutaneous or is a systemic process, and always review meds. Another approach to rash was look for the width, if it is horizontal, the extension, and the depth. For example, blisters are deep, and the evolution. And always listen for alarm symptoms like pain, mucosal involvement, and systemic features. Rash is usually the majority of the time is mild and pruritic, but because the patient have relaxing and remitting course and shortness of breath, that give us a clue to a systemic process. When we talk about fat waxing and waning, we think about syphilis. That is less likely to be a typical, it made it less likely to be a typical bacterial infection. And we talk about a parasite. Because this patient was a young person with fever and rash, we always have to think about infections, mononucleosis, and HIV. When we have a presentation like this, in which the patient has increased volume in the wrist, we have to see if it's septic arthritis or cellulitis, to see if the problem is inside the joint or it's surrounding it. So be careful to examine the skin and joints because the skin and joint are together. It's sometimes very difficult to tell. So when you want to investigate for Tenocenovitis, you move the tendons because you move the fingers because that's what moves the tendons. And always be aware that it's a highway for rapid spread and is a medical emergency, normally caused by infections, staph, strep, gonorrhea. And those should be a reflex that you should treat with antibiotics. Other infectious diseases could be syphilis, Mycobacterium marinum. Autoimmune, it could be a spondylitis or gout. Because this patient have eosinophilia, we talk about the absolute number of eosinophils does not always reflect the grade of eosinophilia, because many times the eosinophils can be in the tissues and not get counted. So when we think about primary eosinophilia, we think about primary eosinophilic leukemia. And when we think about secondary, we think about adrenal insufficiency, secondary to reaction to medication, lymphoma, lung cancer, AGPA, fungal, parasitic, or atypical bacteria like Mycobacteria. And then we learned about this syndrome that is called NERS, nodules, eosinophilia, rheumatism, dermatitis, and swelling. Thank you very much.
Andrea, that was absolutely amazing. And I'm so glad you didn't forget to mention NERDS as the word that captures both the craziest diagnosis, minus gnathosomiasis, and also this incredible community of wonderful people. So nice to see you all, and hope to see you next time.